A couple things, obviously last night was a great night for me. It was a late night. The Eagles did pull it out, and so anyway, I'll start that way. But this week was really an important week. We observed Veterans Day, and I had the opportunity to be in to visit the Pearl Harbor Memorial this last week, and I have to tell you that it's just the most moving thing that I've ever done. Just looking into the water and seeing the oil, and it was, because it had rained, of course, being there, I think it rained every single day, and it rained buckets and feet of water, which made the Arizona's leak happen just consistently, huge oil leaks out of it, and the water was cloudy. But that and the Missouri, just if you haven't ever done it in your life, it's a long trip, but it is just absolutely the most amazing experience actually to walk and look down at that memorial and realize the sacrifice that our veterans have made for this country. So to all the veterans that are in this room, thank you for your service, because we wouldn't be sitting here today as we are as a free country without those sacrifices. So thank you. It's been a crazy week. Obviously, I traveled for 25 hours to get back here 2 days ago. But this program this morning, I think, it's incredibly important to the community. I think we've seen so many of our loved ones, friends, and neighbors affected by dementia and Alzheimer's. While at the same time, there's just incredible advances in detection and early detection and treatment. I think I even saw an article this week in the Hartford Current again. And then this morning, I have to be careful when I say this too, because not everybody's as old as me, but if you got the AARP magazine, this last week, I don't know if it was last week, but it came in my mailbox. It talks about, the super long livers and how, the thought of living to be 200 is not out of the realm of possibility, and that the advances that are happening, I know that there's and Dr. Marley will correct me, but I think the maximum life expectancy has always been set at 120 to 130 years old, because there was somebody who lived to be 123. But it's not just living long, it's living healthy long, I think is what the key takeaway was. So I really feel like these programs are so incredibly important to the community, to our corporators, and thank you all for being here. Just because I think the knowledge, it really does, as you kind of ingest the knowledge, it helps you yourself and the people that are around you when you talk about what you learn in these programs. It helps them achieve that goal, right? Not everybody's going to listen to what you say, but the truth is, the more we talk about the right things, the more we talk about how to live a healthy life and the things that are happening in the world, the more people recognize it, and the more people actually engage and get help, or recognize signs and help someone else to recognize what's going on and help them get to a place where they can actually have a more improved life. So thank you for all being here. And I'm going to introduce the panel, of course, Dr. Riaz and Shatita Chatori. Dr. Chatori has joined us, Michelle Berry, and Kimberly Childs. And I'm not going to take any more time, other than to say, we just sent out an article from Newsweek, which is my personal kind of bandwagon about Medicare Advantage. But we did get to be a big part of a feature article in Newsweek on how the insurance companies are using AI to deny care to patients and the harm that's happening. And that features Bristol Hospital in all the opening, and Mayo's team as a other part. It's an extraordinary work that this reporter did. I was just absolutely amazed. I think we spent the last 6 weeks, collecting data and trying to respond, but we will be sending that around. I know it's going to be posted to our social media accounts, and also, please, if you get a chance, it is a long read, but it is an important read because it really does highlight the abuse that's happening to patients and the harm. So I'm going to turn it over to the panel, and let's get started. Thank you.
Good morning, all. I'm Satya Chatori, geriatric physician here at Bristol Health, a medical group. Today, our geriatric team is going to talk on different aspects of Alzheimer's disease. We hope to educate you all more on this disease, help you all understand this disease better and reduce the fear around this disease. Today I'll be talking on understanding the basics, early symptoms, and risk factors. What is Alzheimer's disease? It is an irreversible, progressive brain disease that slowly destroys nerve cells that damage the brain, that lead to problems with memory and thinking skills, and eventually affect the ability to carry out your simplest daily tasks. This is not a normal part of aging. It's caused by abnormal protein lesions called amyloid beta plaques and tau proteins that form the neurofibrillary tangles. They clog the brain and interrupt the flow of communication between the neurons. Alzheimer's disease commonly affects older adults over the age of 65. It's the most common cause of dementia. 60 to 70% of patients with dementia have Alzheimer's disease. It's very uncommon to see below the age of 60 years. It affects only 5% of people with early onset symptoms. And the different cognitive domains affected are memory, language, executive function, orientation, attention, visuospatial skills, and social skills. What are the early symptoms of Alzheimer's disease? The earliest clinical symptom of Alzheimer's disease is selective memory impairment. What is that? It's called declarative episodic memory, which involves remembering specific events and experiences in one's life. It's memory of events that has occurred at a particular time and place. Example, like remembering what happened at a recent friend's birthday party, or remembering what happened at a recent trip. If you're forgetting those, that's episodic memory loss. What is anterograde long-term episodic amnesia? It's a type of memory loss that prevents the brain from forming new memories that you're experiencing now, including episodic memories, which are memories of your personal events. And the symptoms that can develop as the disease progresses is increased forgetfulness, forgetting your recent conversations, forgetting recent events that has occurred, trouble with speech and writing, forgetting the right words for the things, trouble concentrating, thinking clearly, paying attention, and reasoning. Problems with tasks such as paying bills, balancing a checkbook, getting lost in familiar places or wandering. Sleep disturbances also is one of the early symptoms of Alzheimer's. Then there are some behavior and personality changes that can happen, episodes of anger, agitation, aggression, depressive symptoms, anxiety, loss of interest in activities, lack of motivation to do things, hallucinations, seeing or hearing things that others do not see or hear, paranoia, like acting suspicious without a good reason, delusions, having fixed beliefs that are not true, acting confused with your surroundings, being disoriented with time and place, unable to eat, bathe, dress, or struggle to care for your day-to-day tasks. There is poor bladder and bowel control, that's incontinence. You have loss of social skills. There are changes with your eating habits, with your appetite. There's loss of sense and a sense of taste and smell, and there could be balance problems. These are some of the symptoms. As the disease progresses, you see them. So what are the risk factors of Alzheimer's disease? Genetic risk factors. You have early onset Alzheimer's disease. It's inherited early onset Alzheimer's disease that affects 1% of people with Alzheimer's disease. There is mutation in genes called amyloid precursor protein, presenilin-1 and presenilin-2 that alter the amyloid beta production, and this has autosomal dominant inheritance, meaning 100% there is 100% risk for the family members to develop Alzheimer's disease, which occurs between the age of 40 to 60 years old. Then you have late onset Alzheimer's disease over the age of 65, which can be caused by apolipoprotein gene, epsilon 4 allele. Carriers of one of this gene have 2 to 3-fold increased risk of developing Alzheimer's disease compared to non-carriers. Those who carry both the genes have 8 to 12-fold increased risk of developing Alzheimer's disease. Family history of dementia and first-degree relatives is also a risk factor. And as I said, it's commonly seen over the age of 65. So what are acquired and modifiable risk factors of Alzheimer's disease? High blood pressure, hypertension. How does it contribute to that? So there is stiffening of the arteries that happen with aging and blood pressure levels that can narrow your blood pressures and decrease your cerebral blood flow, that will increase the amyloid beta protein deposition and decrease clearance. That's how it contributes to Alzheimer's risk. Then dyslipidemia, high cholesterol levels such as the low density lipoprotein, which is called the bad cholesterol, normally does not cross the blood-brain barrier, but when there is vessel damage in the brain, it crosses the blood-brain barrier and contributes to atherosclerosis, narrowing of the blood vessels, decreased cerebral flow, and increased amyloid protein deposition. That's how it increases the risk. Whereas the good cholesterol, called the high-density lipoprotein, normally crosses the blood-brain barrier, and which is essential for the metabolism of the neurons and the brain cells. So that is good for your brain. And how do you get that? With physical activity. Improves your high-density lipoprotein, which is called the good cholesterol. Then you have the cerebrovascular disease, cerebral small vessel disease, which contributes to decreased cerebral blood flow that increases your protein deposition in the brain, the amyloid beta proteins, and decreased clearance. Then how does type 2 diabetes and obesity contribute to increased risk? Increased insulin resistance will decrease the activity of insulin degrading enzyme that normally degrades this amyloid beta proteins in the brain. So when there is deactivation of that insulin degrading enzyme, your amyloid beta protein increases in your brain. That increases your risk for Alzheimer's disease. Then you have peripheral and cardiovascular atherosclerosis that can contribute to vascular brain injury and increase your risk for Alzheimer's disease. The other modifiable risk factors, physical inactivity. Exercise improves cognitive function because it increases the hippocampus and the brain volume. Hippocampus is part of your brain that is required for your memory learning. It's very important. So it can increase the volume of that part of your brain. Sleep apnea increases vascular brain injury. There is decreased blood flow to the brain. It can increase the risk for even vascular dementia. Sleep disorders, like normally 7 to 8 hours of sleep is required for your brain to organize your memories, clear the beta amyloid from your brain, and improve your reorganization of your short-term and long-term memory. So if you have sleep less than 5 hours, you have 30% increased risk of developing Alzheimer's and other kinds of dementia. Brain trauma, history of severe brain trauma with loss of consciousness of 30 minutes or more has increased risk for Alzheimer's disease because it also increases the amyloid beta deposition in the brain. Or multiple blunt traumas or concussion injuries, repeated concussion injuries also can increase your risk for atrophy, that is loss of your brain cells and neurons, which can increase your risk for dementia. Medications, sedatives like benzodiazepines, anticholinergics, antihistamines, opioids, and proton pump inhibitors, which is the acid reflux medications, can increase your risk for Alzheimer's on long-term exposure. These anticholinergic medications over the counter, like you see Benadryl, that can block or inhibit the acetylcholine chemical in your brain that is needed for your memory, learning, and attention. So that's how it affects. Then cigarette smoking leads to vascular brain injury. So that can decrease your blood flow and increase your amyloid beta deposition. Excessive alcohol consumption, how does that contribute? It shrinks your hippocampus volume. So that leads to increased risk for Alzheimer's. Nutritional deficiencies, vitamin B12, B6, folate, how do they contribute? They help in degrading an amino acid called homocysteine, which increases the blood vessel injury and increase the risk for stroke and cardiovascular disease. So if they're deficient in that, there is increased level of homocysteine that can damage your blood vessels, clot your blood, and increase the risk for stroke and cardiovascular disease. Vitamin D is important for clearing the beta amyloid from your brain and also the tau protein. It protects the brain from the tau protein. That's how it increases the risk for Alzheimer's disease. Then environmental risk factors such as air pollution and pesticides, they cause neuroinflammation to your brain cells, loss of brain cells and neurons that can increase your risk for Alzheimer's disease. Thank you all, and we can answer the questions at the end of the talk.
I'm going to talk to you a little bit about delirium, which a lot of times people can confuse or misunderstand in the presence of dementia. This is something that I deal with quite often here at the hospital, and we'll go into a little more detail. So delirium can actually be described in about 30 different terms. One of them is a confusional state or altered mental status. Here we also kind of use it, if you've ever seen on a chart, as acute metabolic encephalopathy or toxic encephalopathy. And it can kind of be thought of an acute brain failure. One of the reasons we get concerned with this is it affects approximately a third of patients over 70 that come into the hospital. We usually see about half of them coming in delirious and another half of them developing the delirium while they're here. We do utilize different tools and criteria to determine if delirium is present. And one of them is from the DSM-5, which is the psychiatric manual. So it defines delirium as a disturbance in attention and awareness. This disturbance develops acutely and it can fluctuate in severity. We typically see a disturbance in cognition, and we say that this disturbance isn't better explained by dementia itself. Usually there's some type of organic or metabolic cause that's contributing to this change in cognition or level of alertness. But it isn't so bad, this level of alertness, that it's actually a coma. Here, we often use the confusion assessment method tool, which a lot of times our nurses could do, but typically any provider or staff member could do to kind of help determine if delirium is present. You do need to have the first two features, which is an acute change in mental status with a fluctuating course, again, and the inattention, as well as either disorganized thinking or an altered level of consciousness. So some of the risk factors for delirium could happen as predisposing variables or precipitating. One of the biggest things is age, but also the presence of dementia itself. Some of the functional disabilities can also be a contributing factor, and I know Dr. Shatori mentioned a lot of them, but with dementia we can see changes in everyday functioning, from ambulating, abilities to get dressed, bathe, going to the bathroom, uses of substances, especially illicit substances, smoking, drinking, any drug use, as well as the multiple comorbidities that we listed. So if there's significant heart disease, especially if there's a lot of them, like high blood pressure, heart failure, coronary artery disease, as well as sleep apnea, especially if it's untreated. Medications can truthfully fall under either variable, because medications can also have effects, kind of like she mentioned as well, those anticholinergic medications that can kind of dry out our system. We often use it for overactive bladder. We take our sleep aids. Sometimes we think Benadryl is not a big deal, but it can actually really affect our ability to get confused while we're in the hospital setting, or some of those other stronger sleep aids that people take in the community as well. Some of the precipitating factors that cause delirium while patients are in the hospital itself can include if you had surgery. Anesthesia really can affect the way elderly respond to the post-operative course. If pain is uncontrolled, lab abnormalities, like if we drop our blood counts and we need blood transfusions, if our electrolytes are off, if there's any signs of kidney injury, which can happen as a secondary issue if we're not eating and drinking well, or if there's any, effects to the liver, which can happen when infections are present as well. Infections is probably our leading cause of delirium. Most often we'll see it with urinary tract infections. That's one of our big ones that people come in with, that family members and loved ones often notice there's a change for a patient, as well as pneumonias, and also any kind of acute exacerbation of a chronic condition. COPD exacerbations if they're happening more often, heart failure exacerbations if they're happening more often, especially if it's causing recurrent hospitalizations. So some of the ways that we kind of work through this issue is by non-pharmacological means or by medications. Most of us all try to not utilize medications if we can help it. So here, especially in the hospital, we want to try to make sure that people are awake during the day and sleeping at night. We want to really keep patients on active schedules like they're at home, walking, getting up to go to the bathroom, keeping them engaged with therapy efforts, and making sure like they have visitation and are kind of socially engaged in talking. And then we want to make sure that when we do notice issues of confusion, we try to redirect them in a way that doesn't get them more upset. Sometimes, unfortunately, that can fail, and we do have to utilize medications to try to help reset what's going on with the brain and keep them a little bit more calm and comfortable in their environment. One of the first lines of medications we tend to use when delirium is present is antipsychotics. They do come with risk factors, and we have to really make sure that we are taking into account any underlying heart conditions as well when they're put into place. The goal is always to start low and to keep them on an as-needed basis, so that we don't have to worry about dependence in the future having long-term effects. Once in a while, we do need to consider alternative medications as well, like benzodiazepines. Those are typically your Xanaxes, Ativans. They're specifically used if there's some concerns with alcohol withdrawal or if seizures are present. And there's been a lot of discussion too about the benefits of melatonin and how that can kind of help keep people on a good sleep cycle without kind of some of those other side effects that we can see from stronger medications. So one of the things we've kind of noticed when people get affected with delirium is that it can have kind of poor outcomes both in the short term and in the long term. And a lot of the variables that kind of influence that are how bad it is, how long it lasts, and it can truthfully last anywhere from days to weeks to even months. And if while they're here, if they do have to unfortunately get restrained or tied to the bed to kind of help maintain a degree of safety. If some of those variables are present, unfortunately, it can lead to, an increased risk of death or placement into a nursing home. And we also find that when delirium is present, it can either be a precipitating factor for the development of dementia later on, or if we already know that the person has dementia, it can make the trajectory accelerated and worsen over time. And typically that person can't go back to the way they formerly were. What we've kind of found going forward with this, and because of such the risk factors for patients coming into the hospital, is that if we invoke geriatric and palliative support early, we can sometimes have a better outcome. So that's kind of our team here and what we're trying to explain a little bit more. But geriatrics does kind of help start interventions early so that we can try to prevent some of these complications. And palliative care can come into play at any point in a disease trajectory, whether there's an acute illness or a chronic one present. And it's really a supportive service that can help with symptom management, emotional needs, and discussion of resources that are available for your loved ones while at the hospital, but as well as in the community, because we also understand the burden of dealing with the chronic progressive disease and how it can kind of affect everybody on different levels. There are more and more resources becoming available, and I think what we find the most kind of help relieve some of your burden and kind of explain what's going on so that you guys can all better understand the situation and not get so overwhelmed yourselves too, because not only does dementia affect the person, but it affects those around them. A lot of times you feel like that person's lost, but you still kind of have to keep their memory and everything alive. So whenever you guys feel like you need those extra resources, we've got a team here in Bristol. I'm going to pass it over to our next presenter.
So I think I last did this talk when I started. That was 11 years ago here in Bristol. And I was alone. Now we have a team, which is great. But definitely, I don't even remember what I spoke about. I think it was also dementia. Definitely though, the talk is very different now. I think now there's just so much hope, so many new things. And I actually feel very lucky that I fell into this type of practice, practicing dementia, and at this time, because there's just so much going on. I remember, one of my primary care colleagues called me when I was seeing a patient and said, Margarita, who cares about dementia? What's the point of diagnosing dementia? The medications don't work anyway. There's nothing you can do about it anyway. And I could understand where that primary care physician was coming from. It's true. Most of the medications that we had available before really just help symptoms, right? But we knew what to expect, and what to expect is decline. And it's a very difficult disease to deal with for not just the patient, but also the family. And, I've heard before people tell me, when you get a diagnosis of dementia, you just told me something worse than cancer, right? But now, in the same way that we saw cancer before, was a hopeless diagnosis, and now there's just so much you can do about it, that's what we're seeing in the field of dementia. Particularly Alzheimer's disease. So my first message today and takeaway for all of you that I want you to share with the rest of the community is actually how important early diagnosis is. And the reason is there are many ways that we could diagnose now, many ways to get specific diagnosis that I'll talk about, but in particular, the treatments that we have that are new, that are very similar to cancer drugs, are only indicated for the very early stages of dementia, in particular Alzheimer's disease. So Dr. Chituri went through all the early signs, but to repeat, it's not only memory. It could be a little bit of just feeling overwhelmed with tasks day to day, doing your taxes, for instance, making some mistakes with medications. It could be changes in your mood. You've never been sad or anxious before, but now you are. Just the little changes. I think my second message is, do not just attribute it to being 80, to being 70. People think 60 is old. It's not, Kurt. But my point is, if there is a change, don't disregard it. Get it checked, right? And as Dr. Chitori mentioned, it's very complex. The checkup is looking through your medications. Maybe you have something as simple as sleep apnea. Maybe you're taking some over-the-counter medication that's caused harm lately, right? Maybe you just have a vitamin deficiency, but definitely get it checked. So in terms of the new things that we have available, there's even a blood test now that can detect, like I said, the most common cause of any cognitive change, 70 to 80% Alzheimer's disease. There's a blood test now for that, and they've seen that the blood tests are actually quite reliable. It's not approved yet by the FDA for diagnosis, and it's not enough that you get a blood test to diagnose Alzheimer's disease and get access to medications. But I foresee that in the next year or so, primary care physicians will be able to order it and say, you know what, let's just see, right? There's a little bit of change. You have family history. You get that blood test, and then, you know what, it's a little bit abnormal. Let's go see a specialist, right? Let's go to geriatric neurology and do further workup. So the test is available now, and the tests are looking very good. They've only every year, new companies are producing tests that just become better and better, specific molecular tests. Right now, there are two ways to diagnose specifically the most common cause of dementia or any cognitive impairment called Alzheimer's disease. So one is through a spinal tap, and again, you get the same tests, amyloid, tau protein, similar to what you get in the blood, and that can tell us pretty well if you have Alzheimer's disease. Another thing that was previously just used mostly in research for Alzheimer's disease drugs is what's called the amyloid PET scan, and now it's being covered by Medicare. It's difficult, especially with Medicare Advantage plans, to get it covered, but there are ways to get it done now. So there are these new tests that have become available, not just with research, but now actually for the community. In terms of the new medications, so in the past, I'm sure you've heard of it, right? Aricept, Namenda, those medications, while they were not very, very effective, they help modestly, they at least help symptoms, right? Symptoms of memory loss that could get frustrating. We have a lot of medications that help the mood, the anxiety, the depression, the complications of Alzheimer's disease and other types of dementia. But now the new medications, they're called lecanemab and donanemab, or Leqembi and Kisunla. I'm sure you guys have seen it all over the news, right? So I remember there was even one medication during the pandemic. I had to present it to executive committee of the medical staff. This was maybe 2020. It was the first medication. It was called aducanumab. And I had to present it because there was so much negative press about it, right? Because the FDA approved it, but no, it didn't. There was conflicting data. So we were giving that, I think about 4 years ago, we were giving that. But now, I think this month, it's no longer available. But that's okay, because it paved the way for these two new medications. Another misconception is you think these are new medications and you hear, I don't want to be the guinea pig for these medications, right? They're new medications. How long has this medication been approved? But one of the things I recently learned is that these medications, these type of medications are called monoclonal antibodies. So they're like the cancer drugs. They target specific molecules, in particular amyloid that builds up in the brain. They've been studied for 40 years. And it's just that it's only in the past 5 years that finally there are studies that were actually successful. So, we always say, right, it's okay to fail as long as we're failing forward. So we failed for 40 years, but in the past 5 years, we've seen hope, because we've seen that there is actually effects, not just on removing the amyloid, but when you look at the graphs, of the study, so this is what you typically see in published in the studies, you see that there's actually 30% less decline at 1.5 years in cognition or brain function, in day-to-day abilities, the ability to drive, to do your taxes, to manage your medications, to stay at home. In terms of mood and behaviors, feeling anxious, depressed, even data to say that it affects quality of life, not just of the patients, but also of the caregivers. It affects caregiver fatigue. So you think 30%, but that 30%, like I said, could mean the difference between being able to stay at home and not in a nursing home. One of the other misconceptions, and I think just the change in mindset now with these new tests and treatments, is that, first of all, people used to think that Alzheimer's disease is the worst type of dementia. Just, you have Alzheimer's, it's the worst thing, right? It's almost like people say, are you telling me I'm crazy? That's not the case, right? And if anything now, when I give a diagnosis, when I say, you know what, we figured out through your spinal tap, through amyloid PET, that it's actually Alzheimer's disease, I say, before I couldn't even say specifically that it's Alzheimer's disease unless you had an autopsy, right? But now, when it's Alzheimer's disease, I somehow actually feel even more glad that, you know what, we found a cause, it's Alzheimer's disease, and this is the only type or cause of cognitive impairment or dementia that currently we could do something specific about. So this is actually not bad news. Of course, you don't want to hear that you have cognitive impairment or you have a diagnosis of Alzheimer's disease, right? I wish it was all normal. But you know what? We can actually do something about Alzheimer's disease now. That's pretty effective. So that's Alzheimer's disease. We have these new medications. They're pretty effective, definitely much better than the medications that we had before. But it's not always good news, right? The medications definitely are, again, hard to get covered by Medicare Advantage especially. Dr. Chituri said that it's less common to have Alzheimer's disease in people who are younger than 65. But I can tell you, while I used to see people mostly in their 70s, 80s, and the picture was mostly, they had a blank stare, they needed help. More and more, the people that I'm seeing in the office, because I've been here also for 11 years, are family members of people that I used to take care of 10, 11 years ago. And for me, that's great. More and more, I'm seeing the children of my previous patients. And for me, that's great, right? But it's more them because they saw how painful and how much suffering the disease could lead. That slow decline, whether it's a blessing or a curse, is actually what pushes people to not want to go through the same thing, especially the family members and the children. So, we're in a community, right? I see so many familiar places here that I've seen from 10, 11 years ago. We're a community that takes care of each other. I always hear it's the neighbor that's taking care of that the power of attorney. A neighbor can be the power of attorney now for other people who don't have other family members, who don't have children, who have spouses that have passed, right? So in the same way, you know, let's spread this message to the community, that it's okay, there's no stigma. If there's a little change, get it checked. If there's Alzheimer's disease, we could do something about it. It's the most common. And so get it checked out, right? So so there's no early age. It's never too early to get it checked. People say, you know, when they come with their children, is it even worth it considering the medications? I don't see any change. Well, that's exactly where these medications can be most effective, when it's so hard to notice, when it hasn't affected your day-to-day abilities, driving, when you're still working even, it could help you work longer, function more in the community, volunteer. So the medications are you can only qualify for it in the early stages of Alzheimer's disease. So it's not all good. There are, it's complex getting it covered. You have to do frequent MRIs. You have to see me or Dr. Chituri very closely every month for the first 6 months. It's an infusion. You have to go to an infusion center. Some people don't want to do it just because, you know, they have to get it through the vein and people are scared of needles. So it's not simple, but it's available and it works much better. There are problems that could affect, that there are side effects that could happen with it. You could get flu-like symptoms, for instance, allergic reactions to the medications. But the most concerning side effects in particular, that's why it needs very close monitoring, is swelling in the brain and bleeding in the brain. It's not very common. It's a very complex decision because we have to check your genetic makeup, like Dr. Chituri explained, to see what your risks are. We have to make sure that there's family involved or a care partner, whether it's a friend or a neighbor, to make sure these patients are very closely monitored, especially the first 6 months of treatment. You have to expect to be on the treatment for more than a year and a half. There are differences between the two medications, and it's again a complex decision because one is every month, one is every 2 weeks, one has a higher risk of bleeding or swelling in the brain, one has less, one you can stop after 2 PET scans that are negative, one you cannot. They work differently. The one you cannot stop works on both large and small types of amyloid. The other one just removes the bigger type. So risks and benefits to both medications, but definitely much more effective medications. So to summarize, I think here are the take-home messages that I want you all to share with your family members, your friends, your neighbors, and the community. The first is the importance of early detection. Do not ignore the little changes. Because if you don't get it checked, if you don't know what you're dealing with, you don't have complete information, then poor outcomes will happen and poor decisions will be made. The second thing is Alzheimer's disease. We should remove all stigma. If anything, Alzheimer's disease is the most hopeful diagnosis nowadays because there are these treatments that actually affect the trajectory of the disease progression. I think those are my 3 messages: early detection, hope, and remove the stigma. And take care of the community, right? Be encouraging to the community about getting this checked. The end, I think, there's one of the things, I didn't even know this. I didn't know that the first patients that got these infusions were actually patients here in Bristol, outside of research. I didn't know that. I just found out because the Alzheimer's Association told me that. I didn't realize, you do your work every day, you have no idea, right, the effects. One of the things I learned also is that Bristol, our practice, actually has the most number of patients, we were the first, but also the most number of patients getting these new medications. I also didn't know that until the association, the Alzheimer's Association, told us. And I think one of the things I want to stress is the fact that Bristol took a risk in starting a geriatric medicine practice. There's no money in geriatrics, right? But it was a need in the community, and Bristol responded to that. But so, I want to thank the leadership in allowing us to build a practice like this, to build a dementia practice, to even allow us to take the risk on doing infusions, giving us the support. I tell you, I wish the staff were here. There's a team here. But if you see our office staff, there are 4 of them there now. They do all the work with insurance, all the work listening to patients and families, how frustrated they are getting this medication approved, scheduling the MRI, scheduling the appointments, because they forgot what the conversation was. So just the support of the leadership, the hospital, but also the support of the community, I think. Not just in getting the word out there that there's geriatrics, and telling them about our practice, but also, now my ask is, again, to spread the word about early detection, about hope, and about all the exciting things. What's in the horizon is that I think there will be more medications, not just for amyloid, the first thing we think that affects Alzheimer's disease, but maybe tau, which comes later. Maybe, there's a lot of inflammation that happens in the brain. I think there's going to be a lot of focus. It's a spectrum now, right? Someone can have Alzheimer's disease but have no symptoms. People who are joining clinical trials and know their amyloid status, it's called preclinical Alzheimer's disease. The studies now are focusing on people who have no symptoms, prevention of Alzheimer's disease. And I think that's what's in the horizon. So there's so much hope, so much going on. Maybe a year or 2 from now, I'll come back here and tell you all the new things, right? Even the current medications, by January, I know that we're going to hear word from the FDA if they're going to approve, instead of every 2 weeks, monthly. They're waiting to get approved injections, like the weight loss, the diabetes drugs. So much change, so much hope, and so much excitement in this disease. Thank you.
I just want to explain a little bit the role of social work in the practice. My primary role is to be a support to the families, to the caregivers, and to the patients themselves. That could come in the way of emotional support, which they all need. As I think all of my colleagues have said, this is a disease that does not only affect the patient, it affects everybody that is involved in their life. And it's devastating for all of them. So I support them all in any way I can. So emotional support, and also case management, connecting them with resources that they might need in the community, or as the disease progresses, if they are going to need to be looking at facilities. We assist with all of that, and including advanced planning for the future. All of us have ongoing goals of care discussions with patients to make sure that we're honoring the patient's wishes and that everybody's on the same page for what their care plan is going to be. I'll often hold family meetings, that is getting the patients and the families together talking, and so they're getting on the same page. And often that also does deal with conflict. As we know, families don't always agree, so we do our best. I get to be there to provide a safe space for them to all talk at a stressful time, and that be a neutral party, because sometimes that'll bring down the tension a little bit. Some of the community resources we talk about, there are so many, so I just picked a handful. There's so many resources that are needed and utilized. Memory cafes are wonderful. They're social events for people with dementia and their families. The Senior Center here in Bristol holds one. There also Live Well in Plantsville, they do have them. And they're great opportunities for patients and families to come together and meet with other people that are going through the same things. The Senior Center offers so many programs to help keep people active. As we were saying, keeping active both mentally and physically is such a strong point to helping combat the disease. So the Senior Center offers so many programs and activities to keep people active. Caregiver support groups, again, another space for people to share with other people that are going through the same things, so they don't feel so alone. Often, families feel very isolated when their loved one has dementia. And this provides caregiver support groups, provides them an opportunity to meet with others and not feel so isolated. And in-home caregiving, this becomes, as the disease progresses, this becomes more and more of a need for people. And there's many opportunities to get in-home caregiving. There's state waiver programs, specifically the Connecticut Home Care Program for the elderly, which helps them get the financing to be able to get help in the home. And then there's private pay agencies, and there's so many throughout the state of Connecticut, and more are popping up all the time. So we connect them with all of that. And then I did want to just speak about the Alzheimer's Association, which we all work very closely with. It's a global, national, and local voluntary health organization that focuses on care, support, and a lot of research. A lot of the new treatments that are coming forth are thanks to the Alzheimer's Association and all the research they carry on. As part of one of their newer programs is called the Dementia Care Coordination Program. This is a referral service for families to get resources in the community that are specific to what they need. It's a one-on-one interview, and it can be very specialized and very directed towards what they need at that time. The Alzheimer's Association also has a 24-hour helpline. This is immediate assistance, day or night, to a live person. So if they're having a crisis moment, they need help in the moment, they can get a hold of a live person 24 hours a day that can help walk them through whatever they're facing. Again, also able to provide resources needed and direct them in what they need to do. Support groups. They have support groups both for patients experiencing dementia and also for caregivers. They have them virtually, and they do have them in person. And we're very proud here at Bristol that starting in January, we're going to be holding a support group, a caregiver support group right here in this room. So we're already letting our patients and families know that this is going to be here, and people are very excited to hear it. So the response has been great. So I'm looking forward to that starting. And then the Alzheimer's Association does offer continuing ongoing education programs, both for families, patients, and for caregivers, for professionals. And they do this through webinars, they have live events, and everything is on their website. I don't know if anybody's ever been on the Alzheimer's Association website. It is comprehensive. There is a lot of information, and anything you could possibly need could be found there. They have fact sheets, they have loads of resources, they have videos and webinars, they have anything you could need. So I highly suggest, even if you don't have anybody that has Alzheimer's or any type of dementia, it's worth looking into because there's so much information on there. And they do also, while it's called the Alzheimer's Association, they do assist people with all types of dementia. So for the Dementia Care Coordination Program and the helpline, it doesn't need to be specific to Alzheimer's disease. It could be any type of dementia. So I highly suggest we all look at that. Thank you.